Good afternoon, or good morning, even good night, wherever you are in the world. I am Kelsey Lewis, Senior Philanthropy Relationship Manager at the Michael J. Fox Foundation. Thank you for being here with me and our expert panelists as we discuss what can be a difficult, uncomfortable, at times scary subject to talk about and navigate. And for those very reasons, a topic that is not talked about enough, Parkinson's-related hallucinations and delusions. My father was diagnosed with Parkinson's 17 years ago, and in the last 3 to 4 years has experienced these symptoms. So it's a subject close to my heart and one I am so grateful to be discussing here today with our wonderful panelists. Hallucinations and delusions are a symptom that can happen in some people living with Parkinson's. They won't happen to everyone, and not everyone who experiences them is bothered by them. But they can occur, and today we'll be talking about why they happen and what options exist to manage them. But before we get too far into the discussion, a few housekeeping notes. If you have a question, type it in the Q&A box near the middle of your screen. Foundation staff and our panelists will get to as many as we can. There isn't a general chat, so your questions will not appear for everyone else to see. And if you want other helpful information, check out the resource list on your screen. To add captions in English, please click the CC button on the bottom right of the media player on your screen. And lastly, like all our webinars, this session will be recorded and available to watch on demand. The on-demand version has captions available in a few different languages as well. We've got a lot to discuss, so let's get started. Let me first introduce our incredible panelists here today. First, Ava Butler is an organizational development consultant and leadership coach. She was also wife and care partner to Richard Butler, who lived with Parkinson's disease and Lewy body dementia, and wrote a book about her experience called Parkinson's, A Love Story with Dementia for Dessert. Thanks for joining us, Ava.
It's my pleasure and honor. Thank you.
Michael Fitz is a retired assistant dean at the University of Alabama, Birmingham. He was diagnosed with Parkinson's disease in 2011 and is a member of the Michael J. Fox Foundation's Patient Council. Welcome, Michael. Good to see you.
Thank you. Good to see you as well. Thanks for having me.
And finally, we have Dr. Catherine Amadeo, a movement disorder specialist at Mid-Hudson Regional Hospital and an Edmund J. Safra Fellow class of 2019. To build a network of movement disorder clinician researchers across the globe, the Michael J. Fox Foundation, in partnership with the Edmund J. Safra Foundation, developed the Edmund J. Safra Fellowship in Movement Disorders. Dr. Amadeo, thank you for being here.
Thank you so much for having me. It's such a pleasure to be with this amazing group of panelists. Thank you.
Yeah, we've got a good group here today. Very excited. All right, well, I think we should just go ahead and get into it. We've got a lot to discuss. We had a lot of questions about this topic. And I'd love to begin the discussion with you, Dr. Amadeo. Could you level set with some definitions? What is a Parkinson's-related hallucination, and how does it differ from a delusion?
Yes. So hallucinations involve false perceptions. So seeing, hearing, feeling, things that are not really there. It can be, well-formed hallucinations or well-formed voices. They're typically visual, but they can be, as I said, tactile, so sensory, feeling something that's not there. They can be auditory, or hearing something that's not there. It's different than a delusion. A delusion is a false belief, but firm false belief. So that individual believes that to be true. Those are less common, but they can occur. So yes.
Awesome. Thank you so much for making that distinction. And Ava, I'd love if you could tell us a little bit about your husband's experience and your experience with these.
Sure. Thank you for that. With Richard, I think his delusions started before the hallucinations. He had, and his were always very fear-based. Delusions that people were after him, he got involved in a scam and he was going to end up in prison, or things like that. And then the hallucinations were both mostly things he would see and hear as opposed to touching, and in his case, also pretty fear-based. Not, as I say, not the nice 1960s kind of hallucinations. And in his case, they were always about things turning into other things, like commandos were in the trees, or the totem pole had a village of people living in it, or the chairs by the pool were people getting married, or there was a band playing outside in the courtyard where the chairs and the trees were. So things like that.
Okay. Yeah. That's as I said, my dad's been experiencing hallucinations, delusions for the last 3 to 4 years. And it's similar where it started very benign. He would see people in the room and he would ask my mom, his wife and a primary care partner, you know, do you see that? Do you see that person? And so he was able to know, you know, I don't think this is real. But then also after, unfortunately, a hospital stay, which I know Dr. Amadeo will get into a little bit later on, they became very real for him and very scary as well.
Mm-hmm.
Michael, go ahead, Ava. So sorry.
Mm-mm. Go ahead.
Michael, I'd love to turn to what you have experienced because it's quite different than Richard's experience and my dad's experience.
Well, yeah, it was definitely different. I would like see and hear some things. And the most common one that I used to have is I would be in my bed asleep and it sounded like somebody was breaking into my townhouse and I could actually hear them come up the stairs. And it was like really, really terrifying. And it was going on for quite a while until I spoke to my physician and we kind of got it figured out.
Mm-hmm. Yeah. And I know we'll talk about this a little later on, but Michael, yours were due to a medication that you were taking, right?
Absolutely. And
Yeah.
unfortunately, I don't remember the name of the medication. I probably have pushed it back in my mind.
Yeah. Don't blame you. So Dr. Amadeo, you know, it sounds like these hallucinations and delusions, they don't have to happen together. Is that common? Do you hear that quite a bit, or what do you hear from your patient?
Yes. So as we've talked, it can be so variable. It can vary from person to person, as you already said too. Not everyone with Parkinson's will develop these, but we are learning more and more about how common they are, and perhaps even from early on in the disease, perhaps provoked, which we're going to talk about. But they can vary from, you know, we call it minor phenomenon, so feeling like something's passing by and looking and nothing's there, to a more well-formed hallucination, which could be auditory, visual, even a sense, smelling something that's not there, so olfactory. And yes, they sometimes can co-occur with a delusion, but not always. Sometimes somebody doesn't really have hallucinations, but they have delusions. The delusions, you know, tend to be of a paranoid theme, most commonly about a spouse, you know, either infidelity or financial. But again, it can really vary. It can vary. And so we're learning more and more about this because it can just be so heterogeneous in its presentation, differ from person to person.
Yeah. And Dr. Amadeo, what are the precursors to hallucinations or delusions, or what are those warning signs to look out for, or are there?
So, you know, that's where I think that's why this discussion is so important. I think, you know, you may see them coming, you may not, you know, I mean, meaning in your loved one, you may, you know, start to observe things that make you question it. Your loved one affected with Parkinson's and these delusions, hallucinations may talk to you about them, but sometimes we don't hear about them. And it's not until maybe a discussion is brought up by your physician, which we're trying to encourage more to, as far as bringing that up. You know, are you seeing things? Are you hearing things that others don't? And sometimes that's the first time that a care partner is hearing about them. They're like, wow, we didn't know you were experiencing this. So it can vary in terms of also, you know, how it's presenting, but also in terms of insightfulness. So some persons, you know, impacted are actually very insightful that these aren't real. So they may or may not talk about them because they know, oh, that's not real. I'm just going to ignore that. But some people are not as insightful. And so that's where it can really carry into your reality as well, because it's so real for them. Yeah, and I think we're going to talk more about triggers in a little bit, but
yeah. And I think you bring up a good point of, with someone experiencing this, that their care partner, their loved one might not know about. And Michael and Ava, I'd love to kind of go to that. What makes this topic difficult to talk about? I'm happy to talk about that as well. But Michael, I'd love to start with you. What makes this topic difficult to talk about in the first place?
Just really in the first place, Parkinson's in general can be kind of challenging to deal with. And you're already going through this as far as like motor symptoms. And then I know admittedly a lot of people have cognitive issues as well, which I did too. But it's really, for lack of a better term, it's really embarrassing. And you really don't want to necessarily talk about it to anybody because it's already bad enough as it is. And then that's been a particular fear of mine to think that this particular issue could get worse. But thankfully we figured out what was going on and we could address it, and it hasn't happened since. So I'm really happy about that.
Yeah, me too. Very happy for you. Ava.
For us, we decided very early on that we were going to be completely transparent about Richard's Parkinson's, and both the physical and the emotional, the hallucinations, all that kind of stuff. So we were open to talking with people about that. Not like strangers on the street or anything, but people in our spheres, our families, of course, and friends, especially when people were coming over to give them an update of what they could expect with Richard's physical and cognitive issues. One thing, going back to the question of how do you know, for Richard, his hallucinations were extremely real. It was no different than us having this conversation. It was not like he could differentiate. And the way I could tell is that by the way he was talking, but he'd start to look past me. So, if there's somebody else in the room and you're looking past them, he'd be looking behind me, but there was nobody there. So I didn't see anybody there, but he did. So that was always my prompt that something was going on. And then I would say, well, what are you seeing, Richard? Or tell me what's going on. And even though I couldn't see it, I learned the hard way to answer with curiosity, ask questions with curiosity, and support him in whatever way I could.
Yeah, absolutely. And we'll get into more of that conversation later on for sure.
Yeah.
I'd love to turn now kind of back to Dr. Amadeo and the causes of hallucinations and delusions. What are those causes of hallucinations and delusions?
Yeah. So firstly, they may be just part of the disease itself. So they, like I said, not everyone will experience them, but we do think they can be an inherent feature of the disease. So due to the disease itself, and the different neurotransmitters involved and so forth. So it can be a feature of the disease itself. But they may also be triggered, and medications is an important trigger to talk about. So the medications that we use to treat the motor features, the dopaminergic therapies, amantadine, so forth, any of those medicines that we use to treat the motor features may contribute to hallucinations. And so that's something that we're always checking in on, and we should be asking about, and you should be letting us know if you're experiencing this, if there was a new medicine added, or perhaps the dosage was adjusted. This could be a side effect. But additionally, other medicines that you may be started on. So we know that some cholinergics for bladder dysfunction, if you had a surgery and you were put on pain medicines, those can be a trigger. Again, on the topic of getting a procedure done, anesthetics may be a trigger. Infection is another important consideration. So when we hear about acute hallucinations that, you weren't having any and all of a sudden now you are, something we want to think about is what else is going on. So an infection, a urinary tract infection, that confusion, hallucinations may actually be the only feature of it. So that's something to keep in mind. As we get older and as we have a disease that's, like this, like Parkinson's, you may not mount the same response of an infection that you may have earlier in your life, such as a fever or pain. And so sometimes this may be the way that we know we're alerted to something going on. So in fact, a change of environment, I see that, yeah, excellently put on the slide. So I think we talked about, situations where maybe you're visiting a loved one, or you flew on a plane to visit someone, or you're in a hospital setting. That change of environment, the change in the clock where you're getting vitals taken in the middle of the night, those kinds of things can actually trigger these as well. So those are important considerations as we're trying to determine what's going on.
Yeah. And listening to you, Dr. Amadeo, my poor dad, he checks all those boxes. He had all of those, unfortunately, due to Parkinson's themselves, due to UTIs, due to a hospital stay. And that's something I know we've talked about, and I'd love to talk a little bit about, is hospital psychosis or delirium. And how that can also trigger hallucinations and delusions in people with Parkinson's, and am I correct, people without as well. And so it's something that can happen. And if you want to talk to that just a little bit, I think that would be great.
So you bring up a good point in that, honestly, everyone is at risk for delirium. Delirium is a change in your, your mental status with confusion, fluctuations where, there's moments of being more alert and moments of more, sleepy and hard to arouse. Mm-hmm. That's what we mean by delirium. It's an acute change. That's the difference between, say, a more progressive, established process like dementia. So delirium is this acute change in your thinking and cognition, and there's usually a trigger. And anyone, you were right, anyone is at risk for this. And common triggers are infection. We even see this in kids who have a high fever. So anybody could experience delirium. It's just more common in our patients with this disease or other neurodegenerative diseases. And a hospital, so you said hospital delirium, that we also have ICU delirium, again, a situation where, day and night is not so clear because there's always, vitals every 2 hours and things like that. That change in our clock, we really weren't meant, to be awake around the clock. We were meant to sleep at night and be up during the day, which is another important trigger. So when I hear about people having changes in their sleep pattern and so forth, that's another, potential trigger for confusion and hallucinations.
Mm-hmm. Yeah. And that was a term when my dad has been in the hospital a few times. And the first time was just a term that they threw out. And we had no idea what they were talking about, the medical staff. And they seemed to think we should know what that was, because for them, right, it's very common. It is, they do see it. And for us, it was beyond scary for us and my dad and to deal with and try to figure out. So I think that's something we've talked about too, is, making sure that that's more talked about in the medical community and in our community as well. So Michael, I'd love to turn to you. Since your hallucinations were caused by medication, what happened when you changed your medication?
Well, what we had to do, my physician and I, we had to make some adjustments to the medication, and we lowered it. And actually, after we lowered the dosage, it cleared up. But interestingly enough, there's somebody else in my family that has hallucinations as well. So I was able to kind of talk to her about it. We actually kind of helped each other, because it made me feel better that somebody else, could really relate and understand. I don't want her to have hallucinations, but that one little brief little incident really helped us both, I think.
Yeah. And to be able to talk about it and to know, that might happen and you're not alone. I think that was something when my dad experienced that, we were shocked. We didn't know what was happening. And so I'm so grateful again that we have this space to talk about this and that you talk to your family about it too. These conversations are so needed in many different spaces. So with that, kind of along those lines, Dr. Amadeo, will medication related hallucinations and delusions, do they normally go away with medication changes?
So if there is a clear, as Michael said, which thank you so much for sharing your story. Yes, if there's a clear provoking cause, and so we can say, oh, that with that increase in medicine, that's when this happened. Let's try coming back down on it. Sometimes, most of the time, yes, that can be helpful, but keep in mind, like I said, it can also just be a part of this disease. And so sometimes we try to make a change, we try to identify a trigger, and we may not be able to. That may not actually be the trigger, is what I'm saying. And so it may actually just be a part of the disease. But certainly it's always, that's why I always take a look at the medicines. Oh, what's new, what was a change, and see if we can help.
Yeah, absolutely. And Ava, were Richard's doctors able to pinpoint the cause of his hallucinations and delusions?
His doctors told me that hallucinations were not part of Parkinson's. That was 10 years ago, and I pray that's not the case now, but I was the one informing them. There's a lot of education yet to be had. Most of what I learned was through the School of Hard Knocks. I will say that shortly after Richard got diagnosed with Parkinson's, he had knee replacement surgery, and the anesthesia, that was the triggering point for when his hallucinations got worse, and they never got better. So I think with most people, they go to the doctor, they have anesthesia, and you get over it. Like you're foggy for a while, but you get over it. In Richard's case, unfortunately, that was not true. I learned years later that it's a really good idea to, in fact, I would say it's imperative to tell your doctor who's doing a surgery that you've got Parkinson's or and dementia or hallucinations, and be sure that the anesthesiologist understands that. I believe they can change or modify things because people with Parkinson's have a higher susceptibility, or impact on anesthesia than some other people.
Yeah, Dr. Amadeo, will you confirm that for us?
Yes, absolutely, Ava. Thank you so much. Yes. So, I've even been in discussion with some of my colleagues in surgery, neurosurgery, and so forth. And knowing this, and we have come a long way, thank goodness, they will often make a change in, the level of sedation or the type of anesthetic used. And it does help. It does help.
Yeah. And Ava, I think you also bring up such a good point that, you were an expert in Richard, and you knew what was happening to him. You knew what was normal. You knew what was not. My mom is the same. She's the expert in my dad. And to those in the medical community, sometimes I feel like that's not as respected as it should be, or listened to, because they see this, every day in and out. But that's just something I would say is, that needs to be respected. You are in this, you are living this just right beside them, and you are an expert in how they're doing. And when this happens, it's something that's so scary for you and your partner and your family as a whole. So, go ahead.
May I just build on that just a bit?
Yeah.
Don't be afraid of the damn doctors. If they're dismissive of you, don't back down. You've got to be an advocate, be strong in your position, respectful, of course, but don't let people intimidate you or help or stop you from doing what you need to do to be your own advocate or the advocate for the one that you love.
I would echo that. I just want to point out it's because of advocates like Ava and that we've learned more about this. REM behavior disorder is a very important example of something that we didn't know about until we started to hear about, oh, this has been going on for years, 20 years before you came to see, you know what I mean? And we learned it was an important prodrome. So yes, don't be afraid. This is how we're all partners in this together. Yep.
And also, Dr. Amadeo, thank you for what you do and for saying that, because it means so much to those care partners that are listening to this and those with Parkinson's that you do that. My dad's movement disorder specialist is a member of our family. So we so appreciate her advocating for us as well. So, okay, let's go on to treating hallucinations and delusions. Ava, how did you and Richard navigate having these conversations with your doctor?
Well, we were very open about it and learning together, really. I mean, because the neurologist didn't know more than we did. But having open and honest conversations and proactive, I think it's good to go agree, in my case with Richard, what we're going to talk about, and who's going to say what. And so he would be positioned. He never felt embarrassed by this, and neither did I. I wish more people treated Parkinson's and hallucinations and delusions like we treat heart attacks or strokes or cancer. It's just something that happens. There's nothing to be embarrassed about. It's just something that's happening in our bodies. And then, be sure to, like I said, prepare for the meeting. Make sure that tell your doctor what you want to cover, because it's, they're all busy. And then make sure you've got a follow-up plan.
Yeah. And, you bring up just kind of a side note. I work with a great couple here at the foundation who, if you have a care partner that goes with you to these appointments, they actually, leading up to his movement disorder specialist appointment, they make lists, and they don't show each other those lists until they're in the room together. So things they want to talk to the movement disorder specialist about that they both noticed, and then they bring both of their lists into the room to discuss, which I thought was such a great way to do that. If you're lucky enough to have that loved one or care partner with you. So, Dr. Amadeo, how can a person most successfully start this conversation? What about people living with PD who aren't experiencing hallucinations or delusions? Why is it important to talk about it early on?
Yeah. Excellent. So a couple of things. Firstly, lists are incredibly important, and they can make the visit just so much, better in terms of we can gear it toward what you want to cover. So I always encouraged. But yes, so how do we start the conversation? So I think it's something that, generally, going to a specialist who knows about this, it's generally part of our, intake. If you don't come with a big list of things, we'll generally start checking in on symptoms. And so again, we've increasingly learned that non-motor features are part of Parkinson's, right? For years, we've known about the motor symptoms, the tremor and so forth, but we're learning more about the non-motor aspects. And so, a thorough evaluation should include questions about this. Are you seeing things, hearing things other people don't? And I'll say, particularly in my newly onset patients where this is less common, but may occur, I'll say you may not. I'm going to ask a whole bunch of questions, some things you may never experience, but because it can happen, I ask about it, and so that's one thing that going through. Now, if that's not happening in your appointments, then again, that's why these discussions are so important, to spread awareness that yes, maybe, if you're not being asked about it, make sure you're checking in with your doctor about this. I don't have these, but I heard about these. Can you tell me more? Or, I think there are commercials now when we talk about treatment. And so I have been getting questions from patients who don't experience them asking me, like, what does this mean? Will I get this? And so then we talk about it. So, I think it's just, like Ava said, it should just be part of our discussion. As we check in on your motor features, we should be checking in on these non-motor things that may or may not happen.
Yeah, absolutely. And as a movement disorder specialist, walk us through how a doctor thinks about treating these symptoms.
Yeah. So, calling in, which it sounds like Michael's doctor was very good about this, is looking at what are anything provoking. So when I hear about them, I'm looking through, what changes were there. I'm asking them, would you start a new medicine with somebody? What's new? What else is going on? Sometimes you will hear about increased urinary frequency and so forth. And so then we're thinking about maybe let's check for urinary tract infection. Let's make sure we're not missing a trigger that we can, correct. And so that's first and foremost is, is there anything we can correct? We will look to the medicines you're already on that are treating, your motor features and see if, maybe we just need to lower it. This is happening mostly at night. Okay, so at bedtime you're getting this. Maybe let's lower it and see if that helps. When those things, don't help, then we can look to other treatments. And when I say this, I want to make sure we talk about pharmacologic, so meaning medication, and non-pharmacologic, meaning, we don't necessarily have to start something. And so, that's not always the right thing. And so if they're mild, intermittent, maybe the person is insightful to them, but maybe they're not. But when their partner kind of reorients them or validates them, that's helpful. And so validation, I think on this call we heard about therapeutic fibbing, which I love that expression, because I think it's important to give that permission to, it's okay to fib, or to I always say validate. Yep, I see that too. I told them to go away. I want to hear more from you guys about that. But so non-pharmacologic approach is very important too as we think about treatment. But when those things aren't enough, and if the hallucinations are scary and bothersome, or really impacting one's life, their care partner's life, their safety, then we do look to medications. And this is an important topic. So because there are many medicines of the, I guess, anti-hallucination, antipsychotic class. So psychotic is a term that includes hallucinations and delusions. So that's where that term comes from. But many of those medicines are actually not safe in our patients because they can block dopamine, the messenger that we know to be reduced, the messenger of the brain that we know to be reduced in this disease. And so we have to be very cautious. And so we look to those of this class that are least apt or not apt at all to block dopamine. And those three, there's actually three, are quetiapine, clozaril, and pimavanserin, or Nuplazid is the brand name. Quetiapine is Seroquel, if that sounds familiar, and then clozaril or clozapine. Those are the only three that of that class of medicine that are safe. We do use a different class of medicine as well, and for some of us, this is actually one of our first line agents, is of the acetylcholinesterase inhibitor class. And those medicines are like Aricept or donepezil, rivastigmine, Exelon, if you've heard those names. They can help lessen hallucinations as well, and are often well tolerated. And so we do have medications. And again, that's why it's so important to talk about this, because we can help lessen them and perhaps make them less frequent, less severe.
Mm-hmm. And I think that's a good point to share that, for some folks, going on these going on these medications, their hallucinations or delusions might not just go away, but they'll, lessen. I work with another wonderful individual who we were sitting in his living room and he saw a carousel out the window. And he's like, I know it's not there, but I see it. And he said, but I'll take this over what I was experiencing before starting medication. So, okay. So I would love to kind of transition into navigating life with hallucinations and illusions. And Michael, to kind of transition us into this section, I'd love for you to talk about what you would, approach your doctor. How would you approach your doctor about this topic? And then also your loved ones. How do you stay in communications with your loved ones? What would be helpful for you, for your loved ones to ask you?
Well, one of the things, and it's been talked about on this webinar constantly, is really having somebody to go with you on the appointment, because I'm a little bit different. I'm single. I live by myself. So when it comes to the appointment time, I have to go by myself. And, the nature of Parkinson's in general, there's things that I forget. I think that was a great idea about the list to bring. And the other thing that's like really, really pertinent about this point is it seems like because our movement specialists are so busy, there's oftentimes where there's a long extended period of time before you get to see your physician. And during all that time, you need to have a way to communicate. So one of the ways that I communicate with my care team, and it's all about a team, it's not just one person, is there's an, what is it called? It's basically like a login mechanism where you can contact there's a word for it. I can't think of what it was called, but anyway, that's a way to like kind of communicate in between your appointments. And that's really important, because what you don't want to do is, like, say your appointment is like 6 months out, a year out. You don't want to wait 6 months or a year before you have a conversation with your physician about this. This is serious stuff. And so as far as like a family and bringing them in, and I'm really challenged to do this, so I'm glad that we're having this conversation. I think it would be helpful sometimes to bring somebody in that's going to get those stools and those nuggets that you might have missed.
Yeah, absolutely.
Patient portal. That's what it's called. Patient portal.
Portal. I know what you were talking about. I could see it in my mind. The patient portal. And you're absolutely. Oh, go ahead.
So no, I'm so sorry. I mean, I was going to say that's a great idea, Michael. Sometimes people will actually message me before their appointment. Like, I know we're seeing you next week. I just want to make sure we talk about these things. I think, because that's just it. It may come to you at certain times. And so I think that's a great idea, Michael. Yeah.
Yeah. And for you, Dr. Amadeo, to already be thinking about even before their appointment, right? And be prepared for. That's such a great tip. Absolutely.
Yeah, I appreciate it.
Yes. Ava, how did you and Richard communicate about this topic?
For Richard, we didn't talk about them in between episodes. For him, it was just reality. It was just like, we're having this conversation and it lasts an hour and then we do something else. I mean, there was no discussion like, hey, what the hell happened during that hour? Because, for him, it was extremely real. So for me, and I learned this the hard way, because at first I would argue with him. No, there's nobody in the room, which is not helpful, because then I became part of the problem. So I learned to go with it and be there and ask him questions about what he was seeing, which seemed to help him. And I would write down a lot of the things that he would say, because they were profound sometimes. And so I would either just ask him what he was seeing, or if they were fear-based, which they often were, I'd say, well, only those people aren't allowed in the house. They didn't get invited here. I'm going to ask them to leave. And I'd say, I couldn't go too fast. I'd go slow, because he said, don't scare them. But I'd say, all right, thank you for visiting. It's time for you to go. We've got other things to do today. And I would literally open the door. These were people, in this case I'm talking about, scary people with tattoos on their teeth, and things like that. I would say, it's time for you to go. Let me escort you to the door. And I would literally walk to where they were and say, okay, it's time for you to go. And I'd escort them out the door. And that seemed to help. And just be there with him. And I think the most important thing is to be present, get your own voice out of it, your own, this is voice, and just be there and be helpful.
That is such great advice, Ava. And I would like to acknowledge, and I think you would as well, that we're saying this and knowing how hard that is as a loved one, as a daughter, as a wife, to transition to that. So those that are out there that are dealing with this, and this is new, be kind to yourself. Be kind to yourself if you're a person with Parkinson's. This is such an, as we've talked about, uncomfortable topic to navigate and to deal with. So if at the beginning we did the same thing with my dad when he was starting to experience these more scary, very real delusions, his were somebody was after us or someone was after him. And, we were like, no, you're fine. You're fine. Nothing's wrong. No one's here. You're good. And we became part of the problem. Right. And so we've definitely learned to, exactly what you said, Ava, to start asking questions, to see what he's saying. I don't see that, but what is it that you're seeing? And recently we've come across a term, which Dr. Amadeo brought up, of therapeutic fibbing, which I wish I could coin the phrase of who said this. And if anyone knows, please let us know. But it has helped my family so much. And we, as many folks, we're very, honest and, with our father, and my mom is with her husband. And so this tactic of therapeutic fibbing is, it's okay. It's okay to be a part of the delusion or to do these things. Recently, my dad was telling me, there was a lawsuit. It was in, someone in DC. We had to get to DC. There was a lawsuit.
Mm-hmm.
We had to get to DC. And, everything in me wanted to say, there's not, you're fine, you're safe. But instead, I've learned and I've said, you know what? I said, I've got it. I'll book the plane tickets right now. No worries. I'll take care of it. And he was like, the hotel too. And I said, I've got the hotel. No worries. I've got you. You know I've got you. I've got you. And that calmed him down, and he went on and ate his dinner. So, yeah.
If I may add a couple of things. First of all, it is a new skill. I mean, we're learning new skills, just like you're learning a new language or learning how to cook or something. We're learning. So be, like you said, Kelsey, be kind to yourself. If you're the care partner or the person going through this. I would add a couple of other things. One is that if I asked Richard to look at me, I said, look at my eyes for a second. Like it seemed to ground him. And the other thing I would do, and I love what you said, just I've got it, I'm booking the tickets. Remind the person we are safe and secure. We are safe now. It felt scary, but those people are gone, or they look scary, but they're really on our side. Whatever it is, to just don't let it escalate.
Mm-hmm. Yeah, absolutely. Yeah. And Dr. Amadeo, a little to you, circling back, I know we talked about therapeutic fibbing. Are there other things that you've heard from your patients or you would recommend in these situations?
Yeah. So yeah, excellent. You are all doing amazing. And I love be kind to yourself. Yes. But yes, so there are other things. So, validation is one, just like you said, I see them, I got this, I took care of it. I called mom, she's fine, everything's okay. But also distraction. So sometimes when validation isn't going the right way. And I always say too, just like you guys said, you're experts in your loved one. And so you're going to see what works. You're going to try. So everybody's different. So some people respond to validation. Some people respond to orientation, which is, no, that person's not there. Oh, nope, that's a hallucination. Some people respond to that. Some people don't. I just had somebody tell me, I don't want you to lie to me. I want you to tell me, so everybody's different. You're going to see what works. You may even ask them, I've done this, if this happens, or, how would you want me to respond? That may or may not be appropriate depending on your level. So sometimes people, they'll tell you, I want you to tell me the truth. I want you to, or yeah, for me, it's so real. So if I'd actually rather you, go with it. So they'll, they may be able to tell you that. Distraction is an important thing. So I've been in a situation helping a loved one, manage this, or in the hospital where it's happening, and we will distract, let's tell me about your favorite, room in your house. If I'm on the phone trying to de-escalate somebody, tell me about your favorite room in the house. And it's amazing how they'll, you can kind of get them, oh, well, I love our library, and they might tell me more about it. Music therapy. Creating a soothing, calm environment. I often will say music from your heyday, right? So your wedding music, the ones that will invoke pleasant memories can actually be very helpful. The important thing where I said creating a calm environment, what you don't want to do is if it's scary or fear-based, as we were talking about, you don't want to escalate. You don't want to say, no, this isn't true. And then that can, like you said, you kind of become part of the trigger in a way where it's scary, like you're not on my side. So you want to stay calm, talk with a soft voice, and, emphasize safety, emphasize you're safe. That's the important thing.
Yeah. And, I also just, when you were talking about the person, you don't know how they respond. You've got to learn your person, right? You've got to learn what they're doing and what works for them. And I love the thought of asking them kind of before. And as we talked about, right, some people who experience these hallucinations or delusions, they will know that the hallucinations aren't real, but sometimes they don't. So it very much varies. Michael, I would love to turn the conversation to you. And, we've talked about, and I'd like to kind of talk more about how would you like someone to approach you And then also, as you know, you don't have a care partner in the home, do you have other resources that can help you?
Let me
Or
start
ones
with
you'd
the last
recommend?
one. Well, you should have like some type of confidant, even if they're not a relative, a good friend that kind of like understands what you're dealing with and is genuinely concerned. That's one thing that I would do. As far as like how to communicate with me, I like for people to be straight up and just don't beat around the bush. Just tell me what you need to tell me. But at the same time, kind of find like some type of balance. You want people to be sensitive to your needs because it can be a little overwhelming. I found out that I really get more information when I go to the physician, to the doctor's office, because one thing that's kind of like discouraging as far as like communication is some of the pharmaceutical commercials. They'll list all of these side effects or whatever, which is fine, but it can like be overwhelming. And if they could find some type of middle ground, maybe to like communicate that stuff, it can just really be scary. And like they'll end the list of comments or side effects with death, and it's like, wow, did you have to like really drop the bomb on me like that? And so that's how I would prefer to be communicated with. So I hope that helps.
It so helps. And I so also appreciate you brought up. I think it sounds like you're lucky enough to have, a lot of people in your life that love you and our family does too. And I know everyone wants to help. And sometimes, they want to, commiserate or like, this is so hard. And it's like, I know it's hard. Like, I don't need to hear that too from you. But
and
would you,
something
those
too.
loved ones, say it again?
Something too. I think that I lost my train of thought. Forgive me, I lost my train of thought. It might come back to me.
I lost mine earlier. You're totally fine. But what would you say to those, those loved ones that just want to help
Yeah,
so much? They help from them. What do you say to those people?
It depends on who it is, because I mean, the people, in your family and who's got strengths in one thing and maybe not so much in another. So you have to kind of like pick your person. I think somebody said earlier, in order to get your help from it, because depending on who it is, I think you might receive it better from one person necessarily than another. So it could be something. And the thought that I had before too is, as far as like the physicians are concerned, you don't want to drop the bomb on everybody and have, like I said, this long drawn out list of side effects. Let people know that this happens in some people. It doesn't happen in all. So all medications have some type of side effect or what have you, but that doesn't mean that you're going to have a side effect and have all of that come down. So it's nice to know, but then at the same time, you have to like balance it out.
Yeah, absolutely. Yeah. Well, I think our conversation has been absolutely incredible. I can't believe we're closing in a little bit, but I think it's time for our Q&A portion. We have a great first question. I'm so glad someone from the audience asked this. My mother also has mild to moderate dementia. How can I tell the difference between dementia symptoms and delusions? And more generally, what link is there, if any, between cognitive changes and hallucinations and delusions? Dr. Amadea, I'll go to you first on that one.
Sure. So yes, so cognitive impairment, cognitive changes, so changes in our thinking, our memory, our processing, our visual, spatial, the way we see the world around us, may be a feature of Parkinson's, may not. Not everyone with Parkinson's will experience cognitive changes. When we think about more, progression in cognitive impairment, where there's more global involvement across different domains of thinking, so memory, language, visual, spatial, executive function, planning, that's when we use the term dementia. So dementia is more severe cognitive changes, but some people may have mild cognitive, changes, maybe just trouble with one domain, so attention or focus, things like. So it can really vary from person to person. Again, I keep saying vary, but that's just so true in this disease. Things just are different from person to person. And so you may experience cognitive changes, you may not. So cognitive impairment may or may not be present with hallucinations. That's something we've recently, again, I think that's more a better understanding. We've often thought about hallucinations and delusions and cognitive impairment as features of disease progression, so occurring as the disease worsens. And often we've thought about delusions and hallucinations occurring more in those who have cognitive impairment, those who have dementia. And certainly, that is where it's more common. So it is more common in later stages. It is more common in those with cognitive impairment or dementia, more severe cognitive impairment, but it doesn't have to be there. And so you don't have to have cognitive changes to have hallucinations and delusions. It may be triggered by a medication or infection. And again, it doesn't mean that you have cognitive impairment. So when we talk about the difference between delirium and cognitive impairment or more severe dementia, again, the key difference there is cognitive impairment and dementia is not something that happens overnight. It's something that is gradually progressive over time and persistent. Delirium is something that there's this acute change where somebody maybe looks like they have dementia, but it happens suddenly. It happened overnight, and generally there's a trigger. So an infection, medication change. Now, sometimes we hear, mom or dad or my husband or wife, they were fine until this happened. And I think we heard Ava shared that with us, that they never had, her husband didn't have hallucinations until they had a surgery. So we can hear that. And so, why is that? It just may be that there was that stressor just kind of unmasked what was going on. So meaning they're likely that things were progressing, and then that stressor to the body, whether it was physical, emotional, it just kind of unmasked it. It was almost like the straw that just kind of caused a blooming of the symptoms. So we do see that too.
Yeah. I'm very glad that you brought that up, because that's with Ava too, and myself, my dad, now looking back, were we seeing some signs of some dementia, some cognitive issues otherwise? Yes, but he took falls that landed him in the hospital, and it was just like a sudden cognitive decline, and it was so scary. Now that I work in the field, and I talk to so many folks that unfortunately have this experience. But I will also say, when you're going through it as a family, Parkinson's can be very isolating in general for, the person going through it and their families. But this was just next level, right? It was, you just felt like, oh my gosh, what is happening? What do you do? And no one really had the answers for us either, or also expected us to just know this was common, right? So what would you say to those families who might be experiencing this? Anyway.
Me? Okay.
Yeah, go ahead.
Okay. So yes, I guess bringing back that whole, be kind to yourself. How would you have known this was coming unless it happened? And we're learning about this together, and we're going to talk. So, and then don't be afraid to talk about it. Ask questions. We're going to work through it. Certainly, your provider should, looking for triggers if possible, but then also understanding and reassuring that yes, this is also part of the course, and we're going to, again, be your partner in this new part. But yeah.
Thank you. I will move on to the next question, unless Ava or Michael, you have anything else? Go ahead.
Michael, did you have anything? So I would say, I'm sorry, what'd you say?
Oh, I'm sorry, go ahead.
Okay. I just wanted to add, and I'll be brief because I know we got a lot to do. For Richard, cognitive decline was bundled in with this. Executive functioning, which sounds big, but it's really just the steps, like all the steps to load the clothes into the clothes washing machine, or wash the dishes, or dress yourself, like all those things, or speak clearly. Those were all part of it for Richard. So I think we've all said, it's different for other people, but for me, it was just a bundled set.
Bundled package, huh? I'd love to move on to our next question because this is actually one I have as well. There are so many questions around RBD, sleep disruptions, and how do those correlate to hallucinations and delusions? Dr. Amadeo, I'm going to go to you first. Will you also just really quickly remind us what RBD is?
So, yep. So RBD is REM behavior disorder. So when you are in your dream stages, the REM stages of sleep, which means rapid eye movement, that's when you're dreaming. Those who aren't impacted by this disease or similar diseases generally is atonic. So it doesn't have any tone. We are paralyzed. And so that for a safety perspective, if we're dreaming about running from a lion, we are not running from a lion. Now, those with Parkinson's or those at risk to develop Parkinson's, this can occur years before the onset of the motor features or cognitive features, can actually act out their dreams. So it's dream enactment, running, yelling out, punching. So that's what REM behavior disorder is. And so, yes, so sometimes that can be misinterpreted as, my loved one's experiencing something, but maybe they're just dreaming. So then I'll ask, does this happen? Are they seeing things or hearing things that aren't in sleep? And that's the other thing is that those with Parkinson's, we've looked at this too, can have very vivid dreams, realistic dreams, often of a nightmarish quality. They actually looked at this. They're more likely to be nightmarish and then sometimes they may carry through when you wake up. So somebody wakes up and they're still very bothered by this dream and thought it was real. So again, it's working through that, was this a dream? Was this a delusion or hallucination? And that's when is it just happening during sleep or when they wake up from sleep? Those kinds of things.
And would you too, we've heard the term active dreaming. Is that, a part of this? Because my dad does that a lot. He'll be kind of falling asleep, reaching for things. And we've learned that phrase is active dreaming. Would you kind of say this is along those lines?
That is, yep. So we'll say, dream enactment, acting out your dreams. That's what we mean. That is that REM behavior disorder. Yes.
Okay, great. All right, last question to wrap us up. I can't believe it. For Michael, if you are not experiencing hallucinations and delusions, how do you think about talking to your doctor about this symptom now to be proactive?
Really to go to her and just kind of like reach out to her and ask her, what's going on with this, because I'm starting to hear a lot of it. I'm starting to read articles about it. I'm starting to see commercials about it, that kind of thing, and just see what kind of response that I can get from that, because I'm sure she probably gets 50 million questions, but she's always kind and answers all my questions for me. So that's how I would do it.
Okay. Yeah, I think that's such a great tip. Ava, anything else, or Dr. Amadeo, with our last couple of seconds that you want to make sure our incredible audience today knows?
I would just say I'm so grateful that we're having this conversation and learning together and being open about it. And it's a journey. And like I said before, be kind to yourself. It's like learning a new language if you're the person or the caregiver. And just treat it as respectfully and positively as you can.
Mm-hmm.
I would echo that. That was beautiful. Exactly. Well said.
I completely agree. And, as I was looking through the Q&A questions, it was just, I was shaking my head. Yes. Oh my gosh. Yes. Because we've experienced this too, or had questions about everything that was talked about today. And so thank you so much. For those of our audience, I hope this was helpful today. You are not alone. This is something that happens, and you are, I hope this was helpful. Thank you again for being a part of our community and for joining us today. And thanks to our panelists. You guys were so incredible. Thank you so much. We'll be sending a link to the webinar on demand to watch again and share as you'd like. We hope you found today's discussion helpful. And thank you so much and have a wonderful day. Bye.